welcome back to part 3 of our webinar today concerning breastfeeding in the outpatient area. We had a couple of questions that we wanted to ask Linda before we went on with part 3. And the first question that we had for her is, in part 1 we discussed the development of office guidelines to use. To your knowledge, is there any sample office guidelines that are available for pediatricians' offices to adopt?
I am not aware of any that are out there that are on the internet to be downloaded. I do know that the American Academy of Pediatrics does have those 2 articles that I talked about, the 10 steps, and an office policy can be built on that. And then the most thorough one that's out there is the Academy of Breastfeeding Medicine, the first one that was listed in those references. So I would download all 3 of those and then use those as a guideline to develop office protocols.
Okay, thank you. More difficult question for the second question. We are having issues now with many of our mothers who do not consider marijuana to be an illegal substance or one of harm during pregnancy, and often do not admit to the use of it when asked for their history in the hospital. How do you feel? What are the guidelines or any research that's available on the effects of marijuana and breastfeeding?
Marijuana should definitely not be used while a mother is breastfeeding her baby. And I know a lot of mothers don't consider it a serious drug, particularly with some of the political climate that's out there right now in different states making different decisions about it. But it is not a drug that should be used during breastfeeding.
Okay, thank you. Feel free to email or phone in questions during part 3 and part 4. And at this point, we'll go ahead and continue to start with part 3 of Foundations for Excellence for Inpatient Hospital Care.
Thank you, Gail. The objectives that we're going to go over right now is to identify the essential elements of in-hospital care of the breastfeeding diet and the physician's role in supporting this care. Because many times, even though it's in hospital, the physician will have a role in helping to decide what is and what is not done during the hospital stay. It's very important for healthcare providers to understand that exclusive breast milk feeding in the hospital supports duration of breastfeeding, not only for moms who choose to exclusively breastfeed their babies, but also for moms that choose to combo feed. And we talked a little bit about that in the last session, that getting breastfeeding off to a good start and getting through lactogenesis 2 and then on into lactogenesis 3, which is the maintenance of established secretion, that will help a mother get her milk supply to the point that she can then combo feed after she's gotten everything established. So exclusive breast milk feeding is not just for the moms who say, well, that's what my goal is to exclusively breast milk feed for 3 months or 6 months or whatever. It is for all mothers. It's our responsibility to encourage exclusive breast milk feeding during their hospital stay, because it's going to impact both of those populations of mother. So how do we in the hospital impact exclusive breast milk feeding? Well, the evidence tells us that maternal-infant separation is the most important barrier to breastfeeding in the developed world. That any time you separate a mother and a baby from the moment of birth on, you are, in the first days following delivery, having a negative impact on breastfeeding. Skin-to-skin care is defined as the most important post-birth strategy central to initiating breastfeeding. So skin-to-skin should be done immediately after birth. It should be encouraged throughout the hospital stay, and skin-to-skin care should also be encouraged for the next few days and weeks after the mom and baby go home from the hospital. One of the things that we define a good baby as in the United States is a baby that sleeps a lot, or a baby that stays in their crib, a baby that doesn't require a whole lot of holding. And nothing could be further from the truth. Babies and moms are meant to be together, particularly during that first month after birth, because those babies have been accustomed to being with mom for 24 hours a day. So it's unreasonable to think that that mother and baby should now be separated for several hours a day. They need to be together almost all the time, and skin-to-skin care is a beautiful way to accomplish that with the mom and the baby, for that baby to adjust to being on the outside. During that important first hour, you have a baby that's born in a quiet, alert state. It's going to make eye contact very, very easily. If you put a baby between 2 females, its mother and another female, and they speak, the baby will consistently turn towards the mother, showing that the baby actually recognized the mother's voice. They'll cry very little when held skin to skin, and they're usually able to, by smell and by vision, root over and find their way to mom's breast and start breastfeeding on their own many times. They'll start giving those signs of hunger. They'll lick, they'll smack, they'll root towards the mom. The mom also is so eager to see that baby, and putting that baby skin to skin, many of our mothers tell us, is just absolutely the most wonderful part of their birth experience. NRP says that the mother is an acceptable heat source, and they list the mother as a heat source to help thermoregulate to meet a baby's needs. So that's going to help the baby maintain their temperature. Oxytocin levels are going to rise, and oxytocin is a natural pain reliever in the mother, so that's going to decrease any kind of discomfort that she's having, and then it's going to start initiating and maintaining that contact that she has with her baby. When moms and babies are separated, cortisol levels, which is a measure of stress in both the mom and the baby, start to rise. And so you can see this baby that's been separated from its mom. It's laying in an open warmer, which many babies in our state are put on an open warmer immediately following birth. A hat's put on their head, a diaper's put on them, their bands are put on them, they're footprinted perhaps, they are given medications, they might be bathed. A lot of things happen to a baby immediately following delivery that does not include being with the mom. When you get a stressed infant, I want you to look at the expression on the baby's faces in these pictures, that baby with its tongue that's high and in the back of its mouth, and how tight the jaw is, and where the healthcare provider has their thumb in this baby's mouth, how clamped down that baby's mouth looks, and look at the scowl on that baby's face. You can just see the stress that those babies have. And when you have that kind of stress with babies that are separated from their moms, they are going to utilize a lot of the glucose that they have stored in order to get them through this time of being regulated to being on the outside. They're going to use some of those glucose stores for muscle tension and to keep those muscles tight. And then also when you try to breastfeed a baby whose jaw is this tight, many times it's uncomfortable for the mom. So a stressed infant will very definitely affect a mother's able to breastfeed comfortably. The guidelines for perinatal care tell us that mothers who don't require resuscitation should be put skin to skin. And here are the three identifying characteristics. Is that baby a term baby? Is it 36.6 or more? Is that baby breathing with a regular rhythm or crying? Does that baby have good muscle tone? If the answer to these questions is yes, then that baby does not need resuscitation and it should remain with the mother. The baby should be dried off and should be placed immediately skin to skin with that mother. Should be covered with dried linen to help maintain the temperature, and the baby can actually be observed right on the mother's chest for breathing activity and color. All of the things that go in the APGAR score can be done while the baby is skin to skin. So moms and babies should be together unless resuscitation is required. So what we need to turn this into is a mom and a baby having that opportunity to be together right after the baby's delivered. So the bonding time, that thermoregulation of the baby, the maintenance of those glucose levels, the respiratory effort that's trying to stabilize, all those things can be enhanced by that baby being in the least stressful possible environment. The CDC mPINC survey, the 2013 results are out now, and I'm going to explain a little bit more about the CDC mPINC survey, but it is a survey that's done of delivering hospitals, and we just got our 2013 report. And what was revealed in Alabama is that only 62% of all babies in Alabama experience immediate skin-to-skin care for at least 30 minutes in the first hour following delivery. And for C-section babies, it's even less in Alabama. Only about 51% of our babies are having that skin-to-skin care. As far as the impact on supplementation, does skin-to-skin care impact supplementation, which we've talked about how important it is not to supplement babies? Well, is this going to make a difference? If there's no skin-to-skin care in the first 90 minutes following delivery, 74% of those babies will be supplemented during their hospital stay. If there is skin-to-skin care that's done in the first 90 minutes, but it's not done in the OR, and this is for C-section babies, 42% of those babies are supplemented during their hospital stay. But if that baby in the OR following a C-section is actually put skin to skin immediately, only 33% of those babies are supplemented during their hospital stay. So the impact of immediate skin to skin care on babies right after a C-section is absolutely phenomenal. As far as the duration of breastfeeding is concerned, babies who have early contact with those mothers, who are put skin to skin very quickly following delivery, those babies with that early contact, 58% of those moms who start to breastfeed will be breastfeeding at 3 months. Mothers who have no contact immediately following delivery, they're not given the opportunity to have skin-to-skin care, only 26% of those mothers will still be breastfeeding at 3 months. So early skin-to-skin care very definitely impacts supplementation, and it very definitely impacts the duration of babies after having skin-to-skin care for the first 3 months. Rimming in also has an impact on the outcomes that our babies have. And in rimming in, what we are responsible for doing, because of what we know about the things that rimming in can do, is to encourage a mom to keep her baby with her even at night, and to perform any kind of procedures that should be done on a baby in the mother's room. The CDC survey showed that only 47% of babies in Alabama room in with their mothers during their hospital stay, 24 hours a day. And so we've got a long way to go in Alabama with making that the cultural norm. Here's some of the barriers to rooming in that are out there. Sometimes healthcare providers will visit those barriers on the mother. They will say, why don't you get some rest tonight before you go home from the hospital, and you go ahead and send the baby to the nursery and let them just bring the baby out to you because we're concerned that she's tired. Or a member of her family, well-meaning, is concerned about her level of tiredness, and they'll say, this is your last night in the hospital, or you've got 2 other children at home while you're here in the hospital, you send that baby to the nursery, and you let them take care of the baby at night, and, you know, maybe the baby can come out for feedings, but you get the rest that you need. So everybody's concerned about how tired the mom is, and they're giving her that encouragement to send her baby to the nursery at night. Sometimes it's for our convenience as healthcare providers. We will be doing a procedure like a heel stick on a baby to get some blood for a test. And for us, for many, many years, we thought it was more convenient to line all the babies up in the nursery and to do them all at the same time. Well, that involved going down and getting the baby, bringing it back to the nursery, taking that baby away from the mom for a period of time, doing the heel sticks, and then taking the baby back down. And so that is our barrier to moms rooming in. We feel more comfortable doing those tests in the nursery many times. And I know that at our facility we have stopped that. We have started doing all the procedures in the baby's room except for certain things like circumcisions and digit removals and deep vein sticks. And now we're doing all of those procedures out in the mother's room, and what you'll find out is that's actually less work for the staff than having to round all the babies up, bring them in, and then take them all back out again. So the staff has found out that even though it was a transition to make, it was a positive transition not only for the moms and the babies, but for them. Belief that newborns need to be observed. There are still facilities in the United States that have a transition period for babies in which they are put on an open warmer and mom is in her room and the baby is in what's called a transition nursery, and that baby is watched for 4 hours to make sure that nothing's going on with that baby. And that's an old practice that has not proven to be something that prevents any problems at all or that has prevented any bad outcomes. Sometimes mom might need help with infant care and the staff feels uncomfortable providing that assistance, and so one way to not have that come up, particularly during the night, is to have the baby in the nursery with the nursing staff, and that the mom's asleep, she's not asking questions, she's not trying to take care of her baby, and they're in the nursery comfortably rocking babies and having a good time doing that. And then many times mothers just ask for their babies to be taken to the nursery, and the reason that they do is because that is our cultural norm. We started several years ago, quote, allowing moms and babies to be together in their rooms during the night. If the mother wanted to spend the night with her baby, she would say, I'd like for my baby to stay in the room with me tonight. And it had to be a request. I want my baby to stay in the room with me tonight, not the healthcare provider saying, call me if you need something tonight. Your baby will be here in the room with you. And so we've made that over the years, we've made it a cultural norm. And so to change that expectation is going to take giving mothers information on why it's important for them to stay with their babies during the night and their babies to be in the room with them. I did not find a study that addressed the impact of rooming alone on the duration of breastfeeding, but I did find a review of studies that supports the impact of 6 baby-friendly practices, which include rooming in, on the duration of breastfeeding. And what the study found was that compared with mothers experiencing the 6 practices with mothers who had experienced none of the 6 practices of baby-friendly, that those mothers who received that care were 13 times more likely to be breastfeeding at 6 weeks than mothers who had not experienced those 6 practices that were looked at in this study. And those 6 practices are breastfeeding initiation within the first hour of delivery, giving only breast milk during the hospital stay, rooming in, breastfeeding on demand, pacifiers, and then fostering breastfeeding support groups. When those 6 practices were looked at, which includes the rooming in, then those mothers were 13 times more likely to still be breastfeeding at 6 weeks than mothers who had not experienced those. So the impact on supplementation, well, we don't have something that specifically points to rooming in and duration, but we do have information on supplementation and rooming in. And we know that supplementation occurs less often when moms and babies stay in the room together because they breastfeed more frequently. 8 to 12 times in a 24-hour period is what you might see, with many of those feedings being during the night. And the reason that 8 to 12 feedings is so important in terms of supplementation is that it will stabilize neonatal serum glucose levels, so it's less likely for the baby to have a medical indication for being supplemented. It will help to prevent pathologic engorgement. Sometimes when mother's milk comes in, they are so full, the baby has a hard time latching on and breastfeeding, and in order to feed her baby, the mom might have to supplement her baby because I've gotten home from the hospital, I didn't room in with my baby, my engorgement is really uncomfortable because I didn't keep my baby with me at night as my milk was coming in, and therefore my engorgement has gotten out of hand and my baby can't latch on. So now I've got to feed my baby something. Also, those 8 to 12 feedings that go along with rooming in decreases that baby's potential for losing more weight than they should are expected to lose. It promotes the earlier onset of mature milk production, and it decreases the incidence of jaundice. And those 3 things themselves, that appropriate weight loss, the onset of mature milk production, the incidence of jaundice, those are all reasons that babies might be supplemented if those things occur. So preventing those things from happening is an important factor in babies not being supplemented. And then it does, those 8 to 12 feedings in a 24-hour period does increase the duration of breastfeeding. Hypoglycemia in the breastfeeding infant, in both full-term and late preterm infants, is another issue that has to be addressed in the hospital setting. And we know that there are 3 things in the triangle. There are 3 metabolic adaptations that have to take place as soon as a baby is delivered. Number 1, the mom has been regulating the baby's temperature for the baby for the last 9 months, or for whatever length her pregnancy is. All of a sudden, the baby has to regulate their own temperature. So their hypothalamus has to click on and has to figure out what to do now that it's not in an environment that's 98.6. The baby also has to maintain their own blood sugar levels for the first time because mom's been doing that for the baby during the time that mom and baby were hooked together with the umbilical cord. And the baby for the first time has to oxygenate itself through its respiratory efforts. So those 3 things are the 3 most important adaptations that a baby goes through once they are delivered. Well, our evidence-based practices tell us that prevention is the best cure for that. So how do we promote the adaptation of the baby to its environment in the best way? Well, in labor and delivery, the way to do that is for skin-to-skin care to be something that's the expectation of the mom and the staff following delivery. And as soon as the mom gets to labor and delivery and they're describing the processes, because that's just a hallmark of care, is that when you're a nurse, you're supposed to tell a patient what's going to be happening to them. And one of the things that should be discussed with a mom pre-delivery is that she should be told, following delivery of your baby, the best place for your baby to adjust to being on the outside of you is next to your skin. This will help to stabilize your baby's blood glucose, it will help to stabilize your baby's temperature, and it will help to regulate your baby's respiratory effort, your baby's breathing. So it's very important for us to dry the baby off and put it right next to your skin. Mothers, when they hear that explanation, are not apt to refuse that. They are going to be involved in that part of their baby's care. And this should be done for all infants, not just breastfeeding infants. And when you do it for all infants, sometimes those mothers decide once they get the babies on their chest that they indeed do want to breastfeed after all, because this is their first introduction to the baby, and now all of a sudden those mothering hormones kick in and they decide, well, maybe I could try this. You just put that baby next to the mother's skin after you dry it off, put a cap on, and cover the mom and the baby with a warm blanket. And it can be done even in non-emergent cesarean births. And it helps to prevent the things that we have talked about. That's the rationale behind it. As far as skin to skin in the labor and delivery period, the American Academy of Pediatrics encourages that hospitals take a look at their policies and they revise any policies that interfere with early skin to skin contact. So let's say that the policy was following delivery that the baby's head circumference be done, the baby be weighed, the baby be measured, and a complete assessment be done on the baby immediately following delivery. That policy should be revised, and the policy should state prior to the first feeding, if a baby qualifies for skin to skin, it should be put immediately skin to skin with that mother and should remain there until the first feeding is accomplished. The 7th edition of Guidelines for Perinatal Care, once again, just as a reminder, they state newborns that do not require resuscitation should be identified by 3 characteristics and should remain with the mother skin to skin. And they should not be removed for bathing. They should not be removed for weighing. Their examinations are the medications. They're not reasons for removal. As a matter of fact, you can do a lot of that while the baby is skin to skin. So that immediate bathing of the infant, any of that disruption can disrupt that initial breastfeeding behavior that comes so naturally for babies during the first hour or so following delivery. A best practice is to facilitate breastfeeding within the first hour following delivery, and that just kind of follows a natural course following skin to skin. The CDC survey showed that 76% of babies in Alabama do get to initiate breastfeeding in the first hour following delivery. So we're doing better on our initiation of breastfeeding, offering that mother the opportunity to breastfeed her baby, than we are on putting baby skin to skin and letting it kind of follow its natural course to a first feeding. So we really need to work on the skin to skin to get it up there. Early initiation of that feeding, that early feeding opportunity, happens many, many times when babies are put skin to skin. They will just spontaneously find themselves there within the first hour because they have a heightened sense of olfactory learning. They seem to know how to naturally seek out the mother's breast by smell, especially if there's amniotic fluid there. So that's why when you're drying off the baby, you don't want to dry off the baby's hands, because there'll be amniotic fluid on the hands, and the baby's hands will be right up next to the mother's chest, and that scent will be there to show the baby the way to root towards the mother for a feeding time. Immediate skin-to-skin care is associated with a longer duration of breastfeeding, so it very definitely is a best practice. That early initiation, the baby remains in direct skin-to-skin until the first feeding is accomplished. Delay in that first feeding is associated with breastfeeding difficulty, and many references are now saying instead of 1 hour of skin-to-skin that it should be at least 3 hours of skin-to-skin and until the first feeding is accomplished. And it requires that all of those things that we've talked about previously not be done while the baby is, instead of putting the baby skin to skin. So sometimes we have to alter what our perception is of what the most important thing is. Is measuring the baby's head more important than allowing that mother and baby to be together so that they can initiate comfortable, effective breastfeeding? And that skin-to-skin contact is going to give that baby analgesia. So if a baby has a heel stick, or if a baby does get their vitamin K while it's skin-to-skin care and breastfeeding are an important part of making that baby not be as stressed by those events. As far as medical management of hypoglycemia, the American Academy of Pediatrics on fetus and newborn postnatal glucose homeostasis in late preterm and term infants gives a good guideline on which infants to screen, when to screen, laboratory data, clinical signs, and then the management. And that was published in 2011. And I'm beginning to hear that hospitals are changing to these guidelines on how to manage hypoglycemia in the newborn infant. The American Academy of Pediatrics also has a clinical protocol. As a matter of fact, it was the first protocol that they wrote, and it was on the guidelines for blood glucose monitoring. And that's also a good reference to have if you were looking at your policies on how to manage hypoglycemia in the baby. One of the things about management of it is just supporting the mother, not so much, well, what should the blood sugar be and when do you give a baby supplementation and what kind of supplementation, but how do you support the mother if her baby is hypoglycemic? Well, you assure her that if supplementation is needed, it's usually temporary, because sometimes when you give a baby a bottle for a problem like hypoglycemia, unless that's explained to the mother, she thinks that she needs to continue that supplementation. And so if you're giving a bottle for hypoglycemia of whatever, you should say to the mother, more than likely this is the only time we'll need to supplement. We'll be monitoring your baby and making sure that it is not needed again. And if it is, we will use supplementation again, but if it's not, there's no need to think about doing that anymore. Have her pump or hand express her milk for supplementation. Sometimes we jump to the formula instead of realizing that mom might have exactly what's there for her baby. And the very first act that should happen is a mother should breastfeed her baby. And so a lot of times if a mother gets that early feeding in, by the time her baby is monitored for blood sugar, it's already been taken care of because her milk has done the job that it needed to do. But if she's not already breastfed her baby and it seems to be an emergent situation to go ahead and get a measured amount in the baby, then let's see if she can provide that milk, particularly during hand expression. That seems to be the most effective thing that will get milk quickly in that first few hours following delivery. And then if the baby needs to be continually supplemented for some reason, provide her with the means for breast stimulation, because remember, she needs frequent stimulation. She needs stimulation during the first hour to take advantage of those prolactin levels, and she needs frequent stimulation after that to cause those prolactin levels to surge over baseline and then to lay down those prolactin receptors. So supplementing the baby is only part of managing hypoglycemia. Making sure that the mother is getting what she needs as far as stimulation is concerned is just as important. And then remember, if you've got a symptomatic baby who needs to have an IV because of hypoglycemia, it is entirely possible to do skin-to-skin care with an IV line. It's also possible to breastfeed a baby who's got an IV in. And sometimes we forget that about babies. We do skin-to-skin care with babies in the intensive care unit all the time, but when we have a full-term infant that gets an IV, sometimes we forget that that baby can also go skin-to-skin. So let's don't remember that that's an important part of that baby's care, because it will contribute to that metabolic adjustment that that baby's having to make. Stanford University on their website does give their medical management, and it is based on the American Academy of Pediatrics recommendation. And I'm not going to read through it, but there are sources to illustrate that different hospitals around the country are going to these recommendations and are changing the old policies that have been familiar to us for so long. And the key seems to be, of course, whether or not the baby is symptomatic or asymptomatic. So once again, I'm not going to read through that. You can access it on their website, or you can read it here in the slides if you would like to. Hyperbilirubinemia is another issue that can be addressed through breastfeeding management in the hospital setting that can have an impact on supplementation and therefore have an impact on the duration of breastfeeding. And once again, prevention is the best cure. So anytime that we can prevent an issue from happening by adhering to evidence-based practices, then we can decrease the likelihood of some problems that will come down the road because we've supplemented a baby. The American Academy of Pediatrics Subcommittee on Hyperbilirubinemia has some guidelines on management of hyperbilirubinemia in the newborn for infants 35 weeks or more gestation. and that was published in 2004 in Pediatrics. So those are the medical management guidelines out there. And then also the Academy of Breastfeeding Management has a protocol on that, on the management of jaundice in the breastfeeding infant. And what I want to talk about is just jaundice for a moment in general, and the different types of jaundice that you can see, particularly with a breastfed infant, because sometimes I think healthcare providers have a hard time differentiating between the different types of jaundice. Breast milk jaundice occurs in 2/3 or more of breastfed infants to varying degrees, and it can occur most likely in the first 2 to 3 weeks of life, but it can also occur in some babies up to 8 to 10 weeks of life. Some of them are only slightly jaundiced, and some of them are more obviously jaundiced in that second or later weeks of life. And we really don't know the mechanism behind it. We don't know what it is that causes some babies to have a response to something in mom's milk that causes them to carry that jaundice for a longer period of time. Over time, the jaundice and elevated bilirubin levels will start to decline, and they'll get to those normal adult values even while that breastfeeding continues. So whatever it is that's causing that breast milk jaundice, even when they continue to breastfeed, you will see in true breast milk jaundice, you'll see that rate decline, from varying in how fast from infant to infant, but it will decline. There is another kind of jaundice called starvation jaundice, and it's important for us to all realize that all breastfed infants are not going to receive the optimal milk intake during the first few days of life. As a matter of fact, between 10 and 18% of U.S. newborns lose more than 10% of their birth weight during those first few days, and 10% is kind of the maximum that we want to see a baby lose. We'd like to see a baby lose 7% or less, but when it gets up to 10%, then we're getting at the point that if we're going to creep over that something has to be done about this baby's intake, because when you've got a baby that's jaundiced in combination with that much weight loss, then you've got something that needs to be addressed. So in a newborn, when that reduction in caloric intake occurs, you can see an increase in the bilirubin as a result of that. Most often that's seen in the first week of life, but if that caloric deprivation continues, it can be seen later. And the Academy of Breastfeeding Medicine protocol addresses that in their protocol number 22. There is an interaction that can take place between starvation jaundice and breast milk jaundice. And what happens there is you've got a baby that's got poor intake during the first days of life, causing an increase in intestinal reabsorption of the bilirubin, or absorption of the bilirubin, because of that relative starvation. And then breast milk jaundice kicks in when that mature milk comes in, because now we've got the mature milk that might have that element in it that's causing that jaundice to occur, which is a harmless jaundice if it's breast milk jaundice alone, but it can cause it to occur. But when you have the two together, when you've got a baby whose weight gain is inappropriate, and you've got a baby who's also having breast milk jaundice, they can have very exaggerated levels of bilirubin concentration. And so you've got to pay attention to that baby's intake in the first several days, and that's one of the primary reasons it's so important for that early weight check for those breastfeeding babies within 48 to 72 hours following discharge. Because if that baby's intake is not adequate, you can very quickly run into trouble when mother's mature milk comes in, and that component that makes her baby's bilirubin go up, when that component also is added to that starvation jaundice. And then also, we always know that it's prudent, and actually the only thing that is the sure thing in all of this is that you've got to rule out that there's a pathologic jaundice occurring. So not all exaggerations of unconjugated hyperbilirubinemia in breastfeeding infants can be prevented, and so that's one of the reasons for all this close follow-up following discharge from the hospital and assessing these babies for weight loss and weight gain. All of that is key, because just because we do things right in the hospital doesn't mean that we are home free once the baby goes home from the hospital. So we've got to manage things that can occur outside the setting of the hospital, and that management provides us with guidelines on what we need to do. Supplementation versus addressing the management issues. What the CDC tells us about the management of the newborn in relation to the development of starvation jaundice, in other words, what the CDC in their mPINC survey tells us about how our Alabama babies are cared for in relation to feeding is pretty dismal. And I told you I was going to tell you a little bit more about the CDC mPINC survey. The CDC mPINC survey was conducted, it's a survey that was conducted by the CDC to provide participating hospitals with an evaluation of their maternity care as it relates to infant feeding. The evaluation is provided by way of an overall score that ranges from 0 to 100. So just like when your child brings a paper home from school, if they get a score of 90, that's the same type of score that you'll see on the CDC mPINC survey. In 2013, there was an astounding rate of response to this survey. 83% of the hospitals delivering hospitals in the United States responded to this survey. So we got a pretty good look at the kind of care that's being given in hospitals to moms and babies when they deliver, and this care specifically is the care related to infant feeding. The U.S. overall score was a 75 out of a possible 100. So if you are the average mother delivering at the average hospital in the United States, the care that you are receiving that relates to breastfeeding care or infant feeding care is a C. In the state of Alabama, our score was 67. And so our care that our mothers receive in the state of Alabama related to breastfeeding is F care. So we have to understand that some of the things that we can do to prevent hyperbilirubinemia are involved in the care that our mothers receive related to their hospital stay and the kind of start that they get off of with breastfeeding. So the recommended breastfeeding management is the early initiation of breastfeeding, education on what a baby looks like when it's hungry. Many mothers don't realize that they should not wait until a baby cries to feed it, but they should feed it early based on early feeding cues, lip smacking, moving their hand towards their mouth, a baby that's moving around a lot, and you look at the clock and it's been a couple of hours since the last feeding. That's a baby that's getting hungry, and those are the times that we should start feeding our baby. And that exclusive breastfeeding should be encouraged, because when supplementation is necessary, because we are looking at exclusive breast milk feeding as the hallmark of health prevention of problems, and just one bottle does matter, it does change that baby's gut flora, and it changes things about the baby that takes the baby approximately 2 weeks to get past. When supplementation occurs, it's important that we not only use the preferred supplements, which is Mother's Express milk. If you don't have that, banked donor milk, and if you don't have that, then sometimes formula is necessary. But when we do that, we also have to support the mother through that supplementation. So the 3 rules when supplementation is necessary is feed the baby, facilitate return to full direct breastfeeding, and protect the mother's milk supply. When you're feeding the baby, you want to ensure that there's an adequate intake of calories. So in feeding the baby, a lactation consult and an assessment of feeding effectiveness and milk supply is necessary. If it's inadequate, then you're going to supplement with the amount that's needed to have adequate intake. But that's a part of supporting a mother through supplementation, is making sure that a trained provider is looking at what's going on with breastfeeding, so once the supplementation is withdrawn, say in the instance of a baby with hyperbilirubinemia, you start supplementing that baby. Well, when the bilirubin drops, do you stop supplementing? And will the baby get into trouble again because the mother does not have enough milk supply? So you've got to have someone to assess that mom, if you're going to be supportive of breastfeeding, that's going to be able to say whether or not that mother can continue to feed that baby, can stop that supplementation, because yes, indeed, her milk supply is adequate and the baby is feeding effectively. Facilitating full return to full direct breastfeeding means, when possible, avoid the use of nipples and pacifiers because they can have difficulty returning to the breast. We actually know the percentage of babies that will have a hard time. 60% of all babies that take a bottle or a pacifier are going to go back to the breast without any problems at all. 40% will not. And the problem, and they'll have varying degrees, some just a little bit of problem and some with more severe problems going back to the breast. The problem with those percentages is babies won't tell us which ones they are. They won't raise their head and say, I'm in the 40%. And so to avoid the use of a bottle nipple is to the mother and the baby's advantage when it is possible. It should only be attempted if there is a trained provider that is there to teach the mother and to follow up if an alternative method is used. And the two most commonly used alternative methods is the supplemental nursing system and then also cup feeding with babies. But I have to emphasize that it should not be done unless there is someone who is knowledgeable of both of these types of supplementation and can follow up with that mother and make sure that things are going well. And then protecting mother's milk supply whenever a mother is supplementing. And I think one of the most common reasons that prolonged supplementation is done is with an elevated bilirubin. That mother should be expressing her milk every time that baby is given a bottle. So each time a bottle is given, she should be pumping and or feeding her baby equal to at least 8 times a day. And when she pumps, if she's using a breast pump, she should pump for 10 to 15 minutes. That pump should be a good quality pump. It can't be a pump that you might find in some of the discount stores that's a very, very inexpensive pump that does not cycle at least 60 to 80 times a minute. Those pumps are not going to help mother keep her milk supply in or help keeping it come in if it's the early days of breastfeeding. So it's got to be a good quality pump. And as she pumps, she can also hand express following each pumping session, particularly if she's trying to increase her milk production, because the research shows us that pumping in combination with hand expression will help her bring in a better milk supply. And then the post-treatment follow-up, carefully following up with that breastfeeding support to make sure that once that supplementation is withdrawn, that baby is safe to return to full direct breastfeeding by evaluating for that milk exchange that's taking place, and to have that done by a trained provider whenever possible. One of the things about supplementation is that we are now, as hospitals, being held accountable for how many times and how many of our babies are being supplemented. The Joint Commission developed a new perinatal core measure set, and that perinatal core measure set is 5 measures that are care measures: PCO1, perinatal care measure 01, elective deliveries before 39 weeks gestation; 02, cesarean deliveries for first-time low-risk singleton vertex women; 03, antenatal steroids; and 04, healthcare-associated bloodstream infection in babies; and then 05, exclusive breast milk feeding, and 05A, exclusive breast milk feeding considering mother's choice. And so hospitals are being held accountable for these measures, and the National Quality Forum endorsed all 5 of these measures as measures that will help to give a picture of what kind of care mothers and babies are getting during their time of delivery, and then the things that take place following delivery in the hospital. So what we're going to talk about next is supplementation, because of that accountability that we do have. What about supplementation, and how do we handle supplementation? Well, what we know is that 50% of breastfeeding babies have been given formula by the time they're 6 weeks old. So babies who start out breastfeeding, over half of them, by the time they're 6 weeks old, have already been supplemented. So the American Academy of Pediatrics recommendation that babies be exclusively breast milk fed for 6 months, we're not even getting to 6 weeks with that, with half of our babies. Some moms who enter breastfeeding with a goal of exclusively breast milk feeding for 3 months, with those mothers, only 1/3 of those mothers are reaching that goal. 2/3 of the mothers who verbalize, I want to exclusively breast milk feed for at least 3 months and more, 2/3 of those don't reach that goal. So we know that there is a lot of supplementation taking place of our babies in the United States. The Joint Commission reported that the in-hospital supplementation rate was much higher than they previously thought it was. They thought prior to implementing this core measure that it was around 25%, or at the beginning of implementing this core measure. What they found in 2011 is that over half of the babies are actually being supplemented in the hospital. And so those babies at 6 weeks, most of that supplementation actually started in the hospital. So that the care that we are giving is not giving care that is being supportive of mothers who are breastfeeding their babies, to encourage and support them to exclusively breast milk feed. So if we can't get past that first 2 to 3 days, what's the hope of reaching 6 months? So the Joint Commission started holding us accountable. Hospitals that delivered over 1,100 babies per year were required to adopt that perinatal core measure set, and they adopted exclusive breast milk feeding as one of the 5 accountability measures that hospitals have to report on. The Academy of Breastfeeding Medicine has a protocol on supplementation for supplementary feedings for the healthy term breastfed infant. So when you're looking at reasons to supplement, we've got very definite guidelines that are being published out there. And formula supplementation of healthy newborn infants in the hospital is commonplace despite widespread recommendations that we not supplement in the hospital. So all of those factors together have gotten us to the point that we have to very closely look at our care and determine what we can do, what's the appropriate intervention to do to avoid supplementation. Supplementation is not indicated for a baby that's just sleepy in the first 24 to 48 hours. If you've got a baby that's not feeding that 8 to 12 times, it is not an automatic, oh, this baby's not nursing every 2 to 3 hours, so we need to supplement this baby. That is not an indication for supplementation. It's not an indication for supplementation in an infant with a bilirubin level less than 18 after that baby is 72 hours old. So if you've got a baby with a bilirubin of 12, it is not prudent to say, well, let's supplement that baby to make sure it doesn't get up to 18. That's not the prudent thing to do. If that baby doesn't have any risk factors, if that baby is not in that high risk on the butani nonogram for hyperbilirubinemia, then that baby, it's not prudent to supplement to prevent anything from happening. You only supplement babies for hyperbilirubinemia when the guidelines say that that's necessary. Supplementation is not indicated for a baby that's just feeding a lot. When you go into a mother's room and she says, well, my baby fed every 2 to 3 hours last night and, you know, I didn't get a whole lot of rest. It is not the right thing to do to say to that mother, well, why don't you give a bottle tonight and see if that will help him go further. Because we know the prolactin receptors need to be laid down. This is not an indication for supplementation. Supplementation in the hospital is associated with a risk for early weaning. So supplementation in general to prevent some of these issues is not the right thing to do. And then the tired or the sleepy mother, that's not an indication for supplementation. Here are indications for supplementation: hypoglycemia, weight loss that's above 10%, poor feeding, high sodium, delayed lactogenesis with weight loss, delayed bowel movements or continuing meconium stools on day 5, insufficient intake despite adequate milk supply, hyperbilirubinemia. All of these things go into reasons that you should supplement a baby. Intolerable pain with feeding. Sometimes it's a mother issue, or sometimes it's a late preterm infant that's just not able to exchange milk well. There are reasons that we supplement babies. So how much do we supplement when we need to supplement? Well, in the first 24 hours, because of the baby's milk capacity to take in, only about 5 to 10 cc's per feeding is necessary, which is about 2 teaspoons. And you supplement with banked donor milk as your first line of defense if you don't have mother's own milk to use. And then Dr. Nancy White recommends that you go to elemental formulas next, and formula after that, and then in the first 24 hours, water in small quantities. But water is, in general, not recommended after 24 hours at all. In the second 24 hours, pumped or hand-expressed milk, 10 to 15 cc's, supplementing with bank donor milk, elemental formula, or formula if mother's milk is not available, and that's Dr. Nancy White's recommendation on the supplements in the order of preference. In the third 24 hours, 15 to 30 per feeding or to satiety, and then once again, those are the recommended preference of supplementation if you don't have mother's milk to supplement with. And then the methods, here are the methods that are preferred if you've got a trained provider to help the mother with those methods. When you're preparing a mother for discharge, by the time she goes home from the hospital, before a mother is discharged from the hospital, she ought to be able to feed her baby. She ought to be able to understand the importance of exclusive breastfeeding. She ought to recognize that feeding is going well. She ought to know how to get support after she goes home from the hospital. And the physician's role in that hospital care is to educate themselves and to educate their staff, so that they can back up the positive things that are going on in the hospital, and they can advocate for changes to be made if they're necessary, to educate patients, and to play an active supportive role in the development of those policies in the hospital that will support breastfeeding, and also to support the use of pasteurized human donor milk in appropriate populations in the hospital setting. Here are just some quick facts on pasteurized human donor milk. Mothers who donate are not compensated in any way. They have to have written approval from both their obstetrician and their pediatrician saying that they are appropriate for donation. They have to fill out an extensive health history. They have to submit a blood test. They have to agree on certain lifestyle limitations such as caffeine intake, alcohol, medications. And then, after they are approved, their milk is pasteurized when they send their milk in for donation using the Holder method of pasteurization. This method kills HIV, HTLV, hepatitis B and C, CMV, and bacteria including syphilis. The immunological properties are unique to human milk and they are preserved during pasteurization. The macronutrients are unchanged by pasteurization. And then after pasteurization, the milk is tested further to ensure safety. So the mother is tested and those diseases that it kills should not even be present. Then the pasteurization takes place that will take care of those things if they do happen to be in the milk, which they shouldn't be because the mother's already been tested. And then the milk is tested again to make sure that everything's okay. So there is a triple event that takes place that ensures the safety of this milk. And in the 27 years of human milk banking, there has not been, when it's gone through a certified human milk bank, there has not been an incident of an infant being harmed by pasteurized human donor milk. That is the end of part 3.